Well, hello everyone. Good afternoon and welcome to the VCCC Alliance Breast Cancer Grand Rounds. This is our final Grand Rounds for the year, so it's a real privilege to have the speaker who I'm going to introduce in a moment with you today to close out what's been a fantastic year of seminars. For those of you who don't know me, my name is Shom Goel and I'm a breast cancer oncologist and lab head at the Peter MacCallum Cancer Centre and the University of Melbourne. And I'm very delighted to be chairing today's session. Before we begin, I would like to acknowledge the traditional custodians of the land on which we are located today. And I'd also like to pay respects to elders, both past, present, and extend that respect to other Indigenous Australians who are online with us. Before we kick off with today's program, there's just a few housekeeping notes as always. So today's event is being recorded and it will be available on the VCCC Alliance Open Learning page. And you can also go there to watch previous webinars from this series. If you do have any questions for our presenter today, you can do this using the Q&A function on Zoom. This is being run as a Zoom webinar. And I would encourage you to submit your questions throughout the presentation rather than waiting till the end. And we'll aim to get to as many of those questions as we can at the end of this session. So it's my great privilege now to introduce our speaker for today. And that is Dr. Otto Metzker, who is coming to us from the Dana-Farber Cancer Institute in Boston. I'll introduce Otto and his background in a moment, but I think I'd like to mention that in addition to all of his accolades, he's also a very dear friend of mine. Otto and I worked together at the Dana-Farber for many years, shared an office for many years, and have really become firm friends. And so I'm doubly happy to be able to introduce him today. Just to tell you a little bit about Otto, he received his medical degree from the Federal University of Minas Gerais in Brazil in 2003. And he then went on to complete training in internal medicine and then medical oncology, which he finished in 2008. After that, Otto then went to Belgium and spent 3 years at the Institut Jules Bordet in Brussels, which many of you will be familiar with. And there he completed a research fellowship and also initiated his career really dedicated to understanding the biological features of invasive lobular carcinoma, which as we know is the second most common histologic subtype of breast cancer. After that, he moved to Boston, and since joining the breast oncology program at the Dana-Farber in 2012, he has established an active clinical practice, and he's also developed a broad range of research efforts focused on identifying better treatment strategies for patients with breast cancer, and really has a very deep knowledge of breast cancer from both a clinical perspective and also from a scientific and translational perspective. Otto's been involved in designing and leading several clinical trials, both at the national and international level, and often is known for incorporating a strong translational component into those trials. And in addition to his roles as a clinician and as an investigator, he also holds an executive officer position at the Alliance for Clinical Trials in Oncology. So Otto, we're absolutely thrilled that you've been able to find time to join us today. And I'll hand over to you. We look forward to your presentation entitled Challenges in Translation, Invasive Lobular Carcinoma and Our Daily Clinical Practice. Thanks, Otto.
Thank you so much, Shom. Thank you for this very kind introduction. It's an absolute pleasure to join this meeting today and talk about a little bit about lobular carcinoma. Thank you so much for the invitation. It's very nice to join you all for this grand round in breast cancer. And the topic of this presentation is invasive lobular carcinoma. And but the title here is Challenges in Translation and how can we deal with the evidence that we have in our clinical practice. So when we think about invasive lobular carcinoma, the first question here is why bother? Isn't that just a subtype of estrogen receptor positive breast cancer that we should treat the same way? So why study this as a separate disease subset? And here I would say that, given my bias, I would say that ILC or lobular carcinoma represents a unique breast cancer subtype, and it deserves special attention. There are differences in the clinical presentation. There are differences in the way this type of breast cancer responds to therapies. Of course, that there are different patterns of disease dissemination, which we can't change much, and there are unique genomic features. But the real challenge here is how to deal with the limited clinical data and big challenges that we have in the interpretation of subgroup analysis. So when you think about lobular carcinoma, the first reports came from the 40s, and here we have an interesting publication coming from Memorial in New York with a description of lobular neoplasia. And it's interesting that the author said that when the tumor infiltrates, it's so in a peculiar fashion, which is relevant for what we know about lobular carcinoma. And we know that lobular carcinoma can come in different flavors. The classic invasive lobular carcinoma is the most common subtype. It's mostly, in the great majority of cases, estrogen receptor positive, progesterone positive, and HER2 negative. We know that a small fraction of lobulars, about 3%, can be HER2 positive, but there are variants. There are variants, morphologic variants, like solid lobular that tend to be more aggressive, tubulobular, the alveolar, and the pleomorphic lobular, which again can be either HER2 positive or HER2 negative. And the incidence of lobular carcinoma here in this publication from 2003, looking at the period from 87 until 2000, we saw a big increase in the incidence of lobular corresponding to a time where hormonal replacement therapy was common. This makes sense given this is a disease that is classically estrogen receptor positive, so we would expect to see a large increase or maybe a proportionally higher increase in the incidence of lobular when compared to ductal in this period. And we have retrospective series that have looked at the survival outcomes for patients diagnosed with lobular and ductal carcinoma in this classic publication from Pestalozzi, looking at studies conducted by the IBCSG. We can see here in this survival curves for DFS on the left and overall survival on the right, this tendency towards a late pattern of relapse, or in the initial 5 years, we see that ductal tend to have a similar relapse rate when compared to lobular, but as time goes on, we tend to see more relapses among patients diagnosed with lobular carcinoma. And more recently, on a series from SEER and a publication using data from SEER with large number of patients, we saw a similar pattern with this tendency towards a late pattern of relapse. So in this presentation, we're going to talk more about the issues that we have with subgroup analysis, because I think this is important. If we want to talk about lobular, we're dealing with subgroup analysis. We don't have studies. So we need to understand better the definition, interpretation of subgroup analysis and its limitations. And I think that with careful evaluation of the available data, there could be insights into the treatment recommendations looking at this evidence. And more towards the end of this presentation, I'm going to touch base on translational research projects as an optimal strategy to advance the field. So when we think about subgroup analysis, we're looking at the evaluation of treatment effects for a specific endpoint in a subgroup of patients defined by baseline characteristics. That's the definition. This can be biologically motivated. I would say that this is the case for lobular carcinoma, or could it be just when you're looking at the consistency amongst subgroups, let's say when we're interpreting a classic phase three study and we look into subgroup analysis. The concept of heterogeneity is very important. Heterogeneity is looking at the comparison of the magnitude of treatment effects in the complementary subgroups. This can be a quantitative heterogeneity, when one treatment is always better, but by varying degrees, or qualitative heterogeneity, one treatment is better in a particular subgroup, but worse or no different in a different subgroup. And it's also important to remember a concept that's called the multiplicity. And it's common practice for us when interpreting or conducting phase 3 studies to perform multiple subgroup analysis. This is not wrong, but the probability of false positive finding or the type 1 error increases as the number of subgroup analysis increases. So if you have 10 subgroup analyses in a study, you have at least a 40% chance of having one false positive. And you can see this nicely illustrated in this figure. So here, when you look into an example from a phase 3 study, the soft and text trial, here we have 6 subgroup analysis. So we have here a 26% chance of one of these findings being a false positive. The other aspect that's important is this notion of what's pre-specified and what's post-hoc. Basically, pre-specified as in the protocol, it was predefined. Post-hoc, it's a subgroup analysis undertaken after the data have been collected and examined. This may be driven by trends in the data. But it's very important to remember that both the pre-specified and the post-hoc analysis, they suffer from the same statistical limitations as multiple testing problems. So I would say that pre-specified and post-hoc analysis should interpret in somehow in similar ways. And at the end of the day, what matters when we're interpreting subgroup analysis? Well, we need to know if the results are valid and whether the findings are general, they are applicable to our patients and therefore relevant to the decisions that we actually face. And again, not all decisions in medicine are based on data from randomized clinical trials, and we need to improve on our ability to get data from multiple data sources to help with decision making. So with this quick introduction about subgroup analysis and the limitations, I want to dive into how can we deal with treatment recommendations for patients diagnosed with ILC in our clinical practice. So let's just start thinking about adjuvant chemotherapy. We have data from all these studies like this one that point to this notion that ILC tumors have a low response to chemotherapy. So here we have data from 1,000 patients diagnosed from 1985 to 2002. They were all treated on clinical trials with pre-op chemotherapy at MD Anderson. And we see here that the rates of pathologic complete response are lower for lobular. So this comes at a time where there are many series pointing to the same observation, and this sort of perceived notion that lobular was a subtype of breast cancer that doesn't benefit from chemotherapy at all. More recent series, such as the Netherlands Cancer Registry here, with thousands of patients diagnosed with ILC, point to the same observation. We can see here that when you compare endocrine therapy to chemotherapy plus endocrine therapy, the curves are totally overlapping. 40% of these patients were treated with chemo plus endocrine therapy. And in a different publication from the California Cancer Registry, the same. We can see here overlapping curves indicating that chemotherapy doesn't play a role for patients diagnosed with invasive lobular carcinoma. But my question is, are we missing maybe a small subgroup of patients that could potentially benefit from adjuvant chemotherapy, like we have for estrogen receptor positive in general? We know that not all patients benefit from chemotherapy. So there was an interesting publication in 2017, again, using data from SEER, and that included patients who were diagnosed with ILC and for which oncotype scores were available. The authors classified or subdivided the study population using the more recent cutoffs of 25. And we see here that 8% of this population had a high oncotype score. A high recurrence score was independently associated with survival with a hazard ratio of 2.37. But when you look here on the right into the Kaplan-Meier curves, we can see that the curves were overlapping for patients with recurrence score in the intermediate range, but also overlapping for patients with high recurrence score. But here we might have a problem when you look at the follow-up of these patients. When you look at the shape of these curves, basically this series probably included a population with a low risk of recurrence. And I'm not sure if we have power here to see differences in this small subset of patients given the number of events with a survival probability of over 93% for this overall population. So again, are we missing the point? When you look at all the retrospective series, just looking at histologic grade, we can see, as expected, that the majority of patients diagnosed with lobular have low to intermediate histologic grade. But as for ductal carcinoma, we have a subset here in the range of 3 to 5% probably that have a high histologic grade or histologic grade 3. And the histologic grade in itself is problematic for lobular because the classic grading includes tubular formation, the nuclear atypia, and the mitotic count. But we know that lobular doesn't have tubular formation by itself, given its morphologic nature. So the chances of starting with or inflating the histologic grade 1 to 2, it's relatively high. And many years ago, while I was in Belgium, we took this observation and performed a genomic assay in a retrospective series of just under 200 patients diagnosed with lobular using what was called the genomic grade index assay. And here in this series, on the left, including 144 patients or tumors with classic lobular carcinoma, we saw that 16% of these cases were classified as genomic grade high index. And we also included a set of patients diagnosed with pleomorphic ILC. And here it's interesting because pleomorphic is thought to be a high-risk disease. But using the genomic grade index assay, we see that 27% of these patients had a high genomic grade index and a big proportion had low genomic grade index. You can see here on the right in the Kaplan-Meier curves that the association with genomic grade index and survival outcome was statistically significant. So, and more recently, we had done some work using the MIND-ACT phase 3 clinical trial, which is an interesting study because it's a large study that includes 7,000 patients. And what's important here on MIND-ACT is the fact that we have not only the MemPrint results for all patients, but we have the central pathology review of histological subtypes for all these patients included in this study. And when we look here in what has happened in terms of the local assessment of lobular versus the central assessment, we can see that out of 654 patients classified as lobular by local pathologists, when this material was evaluated by a central pathology review by Professor Viale in Milan, who's a very experienced pathologist, we can see that just 395 of these cases were indeed lobular. So there is a fair amount of discordance in the diagnosis of lobular in clinical practice. But here on this presentation, on this analysis of the MIND-ACT, we focus only on patients who had a central assessment of histological subtypes and classified as either ductal or lobular carcinoma. And when we look into the MemmaPrint risk classification, we can see that in the subset of lobular, again, we saw this 16% of cases classified as high risk. It was funny because this is exactly the same number that we had with the genomic grade index some years ago. And for the ductal carcinoma, we know that the percentage is much higher for MemmaPrint high when compared to lobular. The breakdown of classic lobular versus variants was also interesting. We see here that within the classic IOC, 10% had a high MemmaPrint or MemmaPrint high risk. And when you look into the non-classic variants of invasive lobular, 23% were high risk by MemmaPrint. We then looked into the survival outcomes. Here we have the curves for distant metastasis-free survival, which was the primary endpoint of MIND-ACT, just looking to the invasive ductal carcinoma subset. And as we know, patients with high MemmaPrint have a higher risk of distant metastasis-free survival events. But when we overlay here the curves for patients diagnosed with lobular, we can see that despite numbers being small, the survival outcomes were very similar when matched by the genomic risk subset. We went further to evaluate this, trying to be more precise. And here, when we plot the DMF, distant metastasis-free survival by histology and genomic subset, we can see here that there is no significant interaction, or in other words, the MemmaPrint testing is indicating the same prognostic information for patients with either lobular or ductal carcinoma. We can see that the curves were really overlapping. So when we look into different survival outcomes here by overall survival outcomes, we saw the same. The numbers or the curves were really overlapping, indicating that the survival of these patients diagnosed with lobular or ductal was very similar when matched by the genomic subsets. So what are the considerations here for clinical practice? We know that a significant proportion of IOC can be classified as high genomic risk. I don't think it's necessarily easy to identify who is a high risk using classic pathology. So here, there might be some value in using genomic tools. As I said, the survival outcomes was very similar when matched by genomic subtypes. And I would say that omitting chemotherapy for patients diagnosed with lobular carcinoma classified as high clinical risk, like in the MIND-ACT clinical trial, but low genomic risk should be the standard. That's basically what we do anyways. But MemmaPrint may help us identify a subset of patients where the high genomic risk and the prognosis information that we know that's associated with a high genomic risk may help us in the decisions about who should get adjuvant chemotherapy. Of course, that with the number of patients on MIND-ACT, we're not able to investigate the benefit, the actual benefit of chemotherapy by genomic subsets, but that's the best information we have. And I think it's interesting to put that into a clinical context. So now I want to change gears and talk a little bit about adjuvant endocrine therapy and hormonal therapy considerations for patients diagnosed with lobular. So many years ago, we had the opportunity of work with investigators from IBCSG and look at outcomes for patients diagnosed with lobular and ductal carcinoma enrolled in the big 19080 clinical trial. When we did that, we thought that tamoxifen would be the best or similar, we would thought that tamoxifen would have a similar efficacy for lobular versus ductal, given that lobular is such an indolent disease enriched for luminal A features with low Ki67 and so on. In our analysis, we're careful in stratifying our comparisons by the distribution of what we called luminal A A-like versus luminal B-like, basically controlling for differences or imbalances in proliferation, in tumor cell proliferation between lobular and ductal. And we see here that in the lobular subset, the great majority of these patients were luminal A-like with a very low Ki67, and about 27% had a Ki67 greater than 14%. And in the ductal, the division is different as expected. But when we saw the results, we were surprised to see that patients diagnosed with lobular, here shown in the dashed curve in red, had a worse outcome. So this was sort of indicating that there could be some partial resistance with tamoxifen for patients diagnosed with lobular carcinoma. The same was seen for overall survival. When we look into the luminal A versus luminal B, it seemed to be independent. Patients diagnosed with lobular, they did worse when treated with single agent tamoxifen. So this was sort of surprising. We're not expecting to see that. This is retrospective. Who knows if this is just a single finding from Big 19080. So we went back to the same study looking to the 4-arm option of Big 19080 just to try to get a sense of this could be seen in a similar way or not. And when you look into the disease-free survival for ductal and lobular patients in this 4-arm option of the study, basically tamoxifen, letrozole, or the sequencing strategies, we can see here that the curves were basically overlapping or close for ductal, and they tend to separate in the subset of lobular, again, indicating that some exposure to aromatase inhibitor to be very important for patients diagnosed with lobular carcinoma. And the same was true for overall survival, where we see this greater separation in favor of AI-containing regimens in the lobular subset, but no difference in the ductal subset. Again, numbers are small here, but this sort of goes along with our initial observation from the monotherapy arms of the study. And more recently, we did some work using, again, data from SEER, and just here focusing on patients diagnosed with lobular carcinoma and premenopausal setting. Basically, patients below age of 50. Here with SEER, we have advantages of having large number of patients, so 170,000 women with ductal, over 10,000 women with lobular carcinoma, all premenopausal. And when we look into the annual hazard rates of breast cancer-specific survival by histological subtype, we can see some sort of interesting observations here in the shape of these curves. In the ductal subset, we have a tendency towards a slight decrease in the rates of events over time, while for lobular here shown in the green curve, we see that the rates of events over time, and particularly beyond 5 years where the curves cross, it tends to be stable over time. It's sort of concerning. It's unclear how to interpret this or how to put this into clinical context. But the reason why we focused here on premenopausal women is because one could expect that the majority of these patients were treated with tamoxifen monotherapy, although this data is not available from SEER. So some points for consideration here about hormonal therapy. All the data comes from retrospective series. We did see some quantitative heterogeneity of treatment effect in the sense that AI seems to have a greater benefit for lobular when compared to ductal. But the question is, what are the biological mechanisms related to tamoxifen resistance or this partial resistance to tamoxifen in lobular? Or one could even ask, is that really true? So in this last few minutes, I will talk a little bit about some of the ongoing translational research that we have trying to answer some of these questions, and also some additional aspects about how genomics of lobular neoplasia has influenced some of the research that's being done for patients with advanced disease. So we, in order to get additional insights into this difference of endocrine therapies for patients with lobular and ductal, we designed and conducted a study that we're just finishing up now that was called PLOPS, basically a study that included patients just diagnosed with breast cancer. It's a neoadjuvant hormonal therapy trial, and patients were basically enrolled if they had either lobular or ductal histology with pre-specified numbers. They were treated for 2 weeks with either tamoxifen or letrozole, and then the study had a second phase where patients received palbociclib or not. In parallel to that, we're running some preclinical experiments in collaboration with a colleague, Rinaf Jesselson, where we're looking to the differences in ER signaling with a focus starting with cell lines here, cell lines representing either lobular or ductal. And we can see here that the cell lines, both lobular and ductal cell lines, they were dependent on estrogen. And we did see, as had been previously demonstrated, that this models of lobular cell lines, they have some partial resistance to tamoxifen. So there are limitations. We're talking about cell lines, but it's interesting that they seem to recapitulate what we had seen on the retrospective analysis. And the loss of ECAD did not seem to change the way estrogen was affecting these cells, which could be an initial hypothesis given ECAD loss is a common feature for lobular. And we carried over a lot of translational work that we're wrapping up on a manuscript now, really trying to compare differences between the ductal and lobular cell lines. We saw that the cell lines, when you looked at gene expression profiling, they matched very well to gene expression profiling of lobular and ductal patients coming from TCGA. So we believe that although they are limited, given their cell lines, they may represent good models for us to investigate this as an initial approach. But basically, we did a lot of genomics, transcriptomics, and a big focus on epigenetics with ChIP-seq, trying to understand how estrogen or lack of estrogen affects the cell lines. In summary here, when you look into this graphic in the middle, this figure in the middle, which is the FOXA1 binding, we can see that the FOXA1 binding sites are really different in lobular versus ductal. And we believe that this has a mechanism related to tamoxifen resistance. I'm not going to go into too many details about this, given this presentation. I'm trying to have more focus on the clinical aspects, but it's very interesting to see from this type of work that the way estrogen receptor functions in a lobular versus ductal preclinical model is totally different. And this dependence on FOXA1, it's sort of intriguing, and we believe that this may be related to this phenomenon of partial resistance to tamoxifen. So, and what about the advanced disease? What is being done and where is the field going? I would say, well, we have some interesting findings, but we don't have that much information. We know that the genomic landscape of primary lobular tumors, it's slightly different from ductal. We know that CDH1 loss or ECAD loss, it's a major feature for this disease. This was demonstrated in a large series from Belgium here on the left, on a manuscript in the cancer cell by the DCGA group in the middle, and an additional series. But we also have some additional mutations that are relevant, like the PIK3CA is quite prevalent for lobular. And when we go down into the list, we see different mutations, including the FOXA1 itself. When we try to magnify this comparison between lobular and ductal, we can see here on the right that genes related to PI3K signaling, like AKT, the PI3K itself, they're enriched in the lobular carcinoma. We have the HER2 mutations being more prevalent in lobular, which is sort of intriguing and interesting. And again, the FOXA1. The CDH1 or AKT-adhering alterations in the lobular, when compared to the ductal cases, we can see that the loss in the lobular neoplasia, it's more related to somatic mutations. So these are really prevalent alterations that we have in lobular neoplasia. And we don't know exactly why this happens and what really triggers this major difference between these two subtypes. There was some interesting research published in Cancer Discovery in 2018, showing an association between AKT-adhering and ROS1 inhibitor with a synthetic lethality mechanism. So this is interesting because if you have a real synthetic lethality mechanism, this would make lobular quite sensitive to ROS1 inhibitors, and there are clinical trials like the ones listed in the table ongoing at the moment. Since this publication, I've been in touch with companies that are basically highly engaged in ROS1 inhibitors with novel drugs, novel generation of drugs, given what's happening in lung cancer. But investigators at these companies, they were not able to recapitulate this data published in Cancer Discovery. So I decided not to pursue this as an avenue for a potential clinical study in the US. In terms of the HER2 mutations, when we look at large number of patients here, we can see that the HER2 mutations, they tend to be present in 5 to 7% of lobular carcinomas. So this is interesting, and there seems to be some enrichment. We have more of these mutations in lobular when compared to other histologies. And again, it's totally unclear why this happened, but it's a phenomenon that has been described. We have data from clinical studies with neratinib, where we have a clinical benefit rate in the range of 30% for patients with HER2 mutations. And more recently in a study published, presented by Cynthia Ma, evaluating neratinib given in combination with fulvestrant, what we see here on the right was that although numbers are really small, there seems to be a higher clinical benefit rate in the subset of lobulars when treated with this combination when compared to other histologies. So again, limited observation, but it does indicate that for this small subset of patients with lobular and HER2 mutation, there could be a benefit with targeted anti-HER2 therapy given in combination with hormonal therapy. As I mentioned before, 40% of lobular tumors have an alteration that converge to AKT activation. So we have PI3K inhibitors approved in clinical practice. We have mTOR inhibitors. It's unclear if these drugs are better for lobular versus ductal. There's preclinical data indicating that the AKT loss in itself could lead to activation of the pathway independently of mutations. So I think that we need more work into that to really understand the implications to these findings in terms of clinical applications. So to conclude and in summary, and here it does include all my personal bias, I think that lobular carcinoma is sort of a unique breast cancer subtype. I find it interesting to study. There are many aspects that I didn't touch on in this presentation, such as the issues with the imaging problems at the time of the diagnosis, cases who get missed on mammograms, and it's sort of an area that's not my expertise, of course, but it's also very interesting. We note that the benefit of chemotherapy, or I would expect that to be restricted to a small subset of lobulars. And I don't get this idea that lobular should never be treated with chemotherapy. And I think we need to try to identify which are the patients who should benefit from chemotherapy. But of course, I acknowledge the limitations of the data. Aromatase inhibitors seem to be the preferred treatment option for patients that are diagnosed with lobular in the postmenopausal setting. Here, it's an easy assumption, given that AIs are in general a bit better than tamoxifen across the board. The challenge is what to do with premenopausal women, where we still have very limited data, and I hope to have some data on that by additional analysis or planned analysis that we've been discussing with investigators at IBCSG and in the soft and text trials. In the metastatic setting, I think that we still need to do a lot of work. We need to understand better what really drives this pattern of disease relapse. There are issues with imaging, and we're seeing some initial results with genomics, like the HER2 mutation that could be of interest, but again, we're talking about small subsets of patients. And the real conclusion here is that the data is limited. We need to be careful in the interpretation of subgroup analysis, as I mentioned before. The decision and the truth lies in between. We don't have data, and we will not have data from large randomized clinical trials to judge or to help us with our decisions. And of course, clinical judgment is very important. Thank you so much.
Thank you so much, Otto. And just let me start my video. Sorry, we're having a bit of a... Otto, thank you. That was brilliant. And we've got a number of questions coming in. I've got several, but I won't take all the time. But if you don't mind, I'll start, because there's a lot of things that you raised there, which I think for many of us we're sort of aware of, but perhaps not fully aware of how far our understanding has come. And I really want, within the limitations of the data, to get some clinical sort of thoughts from you. So the first one that I'm interested in is this question of chemotherapy in the early stage setting. And I can tell you, to put you in context, that here in Australia, we do not routinely perform genomic assays like Oncotype DX or MammaPrint or such for most patients. So if you had a patient with an early stage lobular cancer that was clinically high risk, let's say it's a largish tumor, 4 or 5 centimeters, there's 3 or 4 nodes involved, and it's reported as a classical lobular cancer, it's low grade, it's strongly ER/PR positive, HER2 negative. What's your approach, and what's the approach of your colleagues with respect to chemo? And then to push it a little bit further, is there some level of clinical risk which would make you move towards chemo in the absence of sort of biological risk?
So thank you, Shom. I think this is an excellent question, and I don't think that we have an easy answer here. So I think that you started from a very good point, in the sense that we need to have some clinical risk to justify, given that the assumption that the majority of patients are not going to benefit most from chemo is true. And if we believe that there is this small subset of ILC tumors that have a high genomic risk, and based on the data from MINDACT, this seems to be the case, and they have a worse prognosis. And it's critical for us to try to identify them in the clinical practice. The challenge with a classic lobular is that we don't have much of the hints that we have for estrogen receptor positive in general, given that they're usually not high grade. And what I always try to do is really try to go into the histological grade breakdown and get a better sense from the mitotic count, because in truth, a lot of what this proliferation of this genomic assays give us is it's information on proliferation. And so for cases where you have a mitotic score of 1, I get less inclined, and I tend to assume that this it's not a case where chemotherapy would make a difference. And here, we have access to oncotype, but I think that we also need to be careful with the interpretation of the genomic assays as well, because I was discussing recently with one of our pathologists, when you send an oncotype for a case of classic lobular that may have low cellularity, I wonder how the pre-analytical tools are really handled when you have, let's say, an oncotype recurrence score or MemPrint or whatever, because we are blind to this type of information. So when extracting the genetic material, there could be a lot of contamination from the stroma. So when I send an oncotype for a patient with lobular, and when I'm trying to interpret the results, I always go into the ER and PR subcomponents of oncotype itself to see if they're positive, because if they're negative, for me, what was tested was probably stroma and not invasive disease. So basically, I think it's very nuanced, and I don't think that we must do genomic assays for all cases. And but I think it's sort of useful given the challenges that we have for a younger patient, where we're really debating on the value of chemotherapy. And for when the clinical risk is very high and we are on this gray zone and we basically can't define, I usually have a conversation with the patients, and I'm not opposed to be error on the indication for a short course of chemotherapy.
Okay, that's really interesting. I think for me anyway, it does help refine my thinking a little bit, that maybe the threshold for chemotherapy in these sort of low-grade classic lobulars should be higher, which I hadn't really thought that through very well. Just one more question, I guess, from me, and then the questions are building. But with tamoxifen, so is it fair to say now that it's routine for you to go straight to an AI in lobular cases if there's no contraindications? And is that, do you push a little harder in premenopausal patients the same, so OFS plus AI over, say, OFS plus tamoxifen?
Yeah, it's sort of I get this question all the time, and I'm really biased, and I think that we should not extrapolate too much into the premenopausal setting, given the limitations of the data that we have so far. But for premenopausal women in general, whenever there is additional risk, if it's not a tiny cancer and we're a little bit more concerned about the risk, I get more inclined in the lobular subset to consider adding ovarian suppression on top of tamoxifen, given what we know from soft and text. Yeah. There is a benefit there. The benefit is across the board. You see more benefit where the risk is. And so I do not always push into an AI, given the issues that we have with tolerability, if the risk is not very high. And occasionally, depending on the age of the patient, I talk about the possibility of offering a few years of an aromatase inhibitor, expecting that the patient is going to go into menopause, depending on the age, or even doing what's not being done on clinical trials, which is a switch strategy for premenopausal women, where you could basically say, well, based on the data that we have, we should expect some benefit, and so a switch strategy could be considered. And in that same line, don't want to diverge too much, but we're going to do a prospective clinical trial with a novel hormonal therapy that's about to start, where the control arm does allow for this type of approach, a switch approach for premenopausal women. And I was glad to see that the regulators were okay with this approach.
Yeah, that is good, because that's something that crosses a lot of our minds, I think, in the routine practice. And on this same note, I'll move on to others' questions now, but first question that came through was from Holly Keane, who's one of our breast cancer surgeons here at Peter Mac and also has done a lot of translational research. And her question is about extended adjuvant endocrine therapy in lobular cancer. Do you have any thoughts about, the use of extended endocrine therapy in these patients? And do you think that any of the genomic assays, for example, the mammoprint score or something else, can help define the extent of extended adjuvant endocrine therapy in lobular cancer specifically?
Well, this is an excellent question, and we don't have real data to say either way. Based on what we know from estrogen receptor positive in general, patients who have a high genomic risk based on any of these assays, they have a higher risk of relapse beyond year 5. So these are probably patients, if you have enough clinical risk plus a high genomic risk, these are patients who might benefit from more than 5 years. But we also have the results from all these recent studies, the data IDEAL and the ABCSG16, basically showing that for a population where with access to screening, let's say patients with, in general, with 1 to 3 positive nodes, not very large cancer, that basically when you reach 7 years, when compared to 10, you don't see differences. So I usually consider for these patients, as I do, let's say for lobular, I would, my process of thought would be the same as for ductal cancer. And I think that all the data that we have, this retrospective data showing that lobular has this higher incidence of late recurrence, it's sort of intriguing, but I'm also makes me wonder if this is really lobular or if this is just a reflect of a different distribution of luminal A versus B when comparing lobular and ductal. Because if you take just ductal cases and you stratify them into luminal A and B, you see sort of the same, that the luminal A subset sort of has this more monotonous pattern of relapse over time. So you would have more relapses early on with luminal Bs. So I wonder if this is really lobular or if it's this difference in distribution of proliferation and the risk associated with that.
Yeah, I guess that's a confounder that we always have to take into account, right, with all of these studies in lobular. The next question comes from Professor Bruce Mann, who's a breast surgeon and actually co-leads the breast program for the VCCC. First, he says, lovely talk, thank you very much. And Bruce says, he's noticed that E-coherent staining is very widely used. And as a result of that, a number of cases that would have been called lobular are not, and vice versa. So how much does that impact the conclusions that we can draw from these historical series is the first part. And then secondly, the role of E-coherent staining when looking at LCIS as well.
So I think this is an excellent question. And I think that there's a lot of variability in the use of E-coherent. So I think that when we look into the retrospective series and where we don't have much control about the assignment or the definition of histological subtypes, I think there is a fair amount of noise into this analysis, but it's probably counterbalanced by the large numbers that is available, let's say, with thousands of patients. So I think that we should be able to interpret some of that despite the limitations. I think that the E-coherent in itself, I'm not a pathologist, but the way I see this is that the staining is not perfect. And there is a fair amount of E-coherent loss in ductal carcinoma as well. And E-coherent itself, when you're trying to see the loss of a marker on IHC, it's not necessarily easy because you're looking into variations of faint stains that are not necessarily, it's different than showing positivity. And there is one interesting E-coherent staining, that's E-coherent P120, that when you have the adhering loss, the cytoplasm of the cell turns completely pink, so it makes it very easy for pathologists to read out. But we have some data using that, again, comparing lobular to ductal, and we see that we do see a fair amount of adhering loss in ductal carcinoma. So the way I see this is that it's a test that it's useful for pathologists, but it should be a complementary test or complementary staining to a diagnosis that, in my view, it's sort of a morphological diagnosis. Yeah. And the lack of adhering in LCIS is also seen the same way, and it sort of helps because their LCIS sometimes the diagnosis is not as easy, and we have this variance of LCIS like pleomorphic LCIS, which it's hard to tell if it's really pleomorphic LCIS or if it's DCIS, and the treatments are different. So having the adhering as a complement could be of utility there as well.
Okay, thank you so much. And Bruce responds in the chat, this answer is important as some pathologists see adhering as definitive. If absent, it is called ILC. So your comments are really important in that context. I'm going to quickly, I know we're sort of running out on time, but we've got a few minutes. So one question from Professor Prue Francis, and then I'm going to move to a question from Professor Jeff Lindemann. So first from Prue, she asks, is it possible to test preclinically if tamoxifen would be as good as an AI for lobular cancers if there was no PIK3CA mutation present?
That's an excellent question, and I would expect to be able to see that on the PILOPS trial, where we're doing basically we're doing exome sequencing for all cases that were enrolled in the study. So we'll at least have some in vivo sort of patterns of response measured by Ki67 or other genomic features by PIK3CA status. I'm not aware of real data looking into that, and I know that this information is partially available on Big 9080, but we're not able to get into this level of granularity given the numbers.
Yeah. And I guess on that note, Jeff has a couple questions. The first one is, I think he's referring to PELOPS when he says, can you just kind of review or explain the rationale for the, he writes the letrozole plus or minus palbo adjuvant study, and also for the TAM versus letrozole lead-in. So I think, you know, just to go over a little bit what your primary sort of goal of designing the study that way is.
Sure, absolutely. So PELOPS was basically a study that we designed soon after seeing the results from Big 9080, and basically trying to get paired research biopsies for patients diagnosed with either ductal or lobular carcinoma and exposed to tamoxifen or letrozole. Given that conducting window studies with two biopsies is not necessarily easy, and at the same time, we're conducting PALAS. We didn't know about the results from PALAS, and with all the enthusiasm about the CDK4/6 inhibitors, we decided to build this second part of the study that with this randomization to the addition of palbociclib in a 2-to-1 randomization. And basically, for this second phase of second part of the study, the idea was really to try to understand benefits of a CDK4/6 inhibitor independently of histological subtype. And we didn't want to be restrictive in the sense that we wanted to enroll premenopausal women into the study. And after a prolonged discussion and review of all the data with pre-op hormonal therapy, we decided to do it with tamoxifen and ovarian suppression for the premenopausal women, given that the differences between suppression with tamoxifen and AI for a few months was not expected to be large, and it's just easier for patients and for the the way the study was built, given you can give the medications at the same time. And to our surprise, PLOPS is a study that enrolled a very large number of premenopausal women. And we basically had a third of our study population, they were premenopausal. And so there's a lot of interest, at least from our clinicians, in getting patients who had, most cases, favorable pathology or genomic features that we're trying to get into a treatment without chemotherapy before surgery.
Yeah, no, we're very looking forward to seeing sort of the deep analysis of that study. And I'm going to squeeze, I'm probably breaking the rules, but just a very quick last question from Jeff is, do you think there might be preferential tumor survival pathways used between lobular and ductal cancers that might relate to FOXA1 or AKT signaling, etc.?
I would say, I would expect that to be the case. And we're really trying very hard to understand and sort of take our findings from these preclinical experiments into PLOPS. And a lot of the, and in reality, we've seen some of the results, and we're trying to wrap up for an abstract and a publication. But the real challenge with the pre-op hormonal therapy has been the definition of response, given that these patients, they have a fair amount of residual disease, and we have issues with evaluation of Ki67 at the time of surgery, particularly with CDK4/6. So what we decided to do, and this is a work in progress, which I believe might be useful for us, is to do RNA sequencing on triplicates at baseline, week 2, and time of surgery, and try to get a very refined data set of at least 100 patients for which we're really able to dive into this questions related to biology and see if what we're seeing in the preclinical side with the FOXA1 and all these things, which I believe it's real, but we want to understand how this plays out in relation to the therapies on using samples from this study.
Yep, no, that's wonderful. And look, we're really out of time. Prue's made one more comment. Otto, I'll send it to you as an email. It's about, oh, you can see it there, about capecitabine and some thoughts about capecitabine in lobular cancer. But I think in the interest of time, I'm going to have to bring the webinar today to a close. Look, thank you so much, Otto, for that. You can tell from the number of questions that people are thoroughly interested in this topic, and that your talk has really stimulated us a lot to think about lobular cancers through a modern lens. And also just to the audience to point out that this was the last grand round for the year. And we'll be back with a new program that starts in February of 2022. And, I'm sure we're going to have a great lineup of speakers. One speaker who I know will be talking to us in February next year will be Professor Beth Mittendorf, also from the Dana-Farber. So we're going to get off to a great start. And with that, I'll close the session. Otto, thanks once again. And wish everyone a safe end to 2021. Thank you.